Thank you for coming today. I would like to introduce our trio of speakers from the project Generation Connect. We're really excited to have this group from Generation Connect because they have had a diversity of experiences in bringing technology to help people living with dementia, specifically mobile applications. And this is something that we are trying to better understand. So their group is leveraging evidence-based interventions for the treatment of dementia-related symptoms. And today they're going to be talking about their initial prototyping, their preliminary findings, their experience in translating research to the home care industry with a product demonstration and an overview of some of their future research objectives. The people that we have visiting us today include Michael Pottinger, who is the COO for Generation Connect with his sister Nicole. I like this, that they were inspired to pursue a career in aging after teaching their 85-year-old grandmother how to use an iPad, who is still using an iPad actively. So Michael works at the intersection of caregiving and technology. We also have Debbie Dodds, the Director of Caregiver Engagement, who has a master's of gerontology in aging services from UMass Boston and is an advisor to the program. She was an employed family caregiver for her mother, who lived with Alzheimer's disease for 10 years. So she represents an early pioneer in the use of tablets for personalized engagement for individuals who are living with dementia. And Robin Lombardo is here as well. She's a geriatric and dementia specialist. She's a veteran of the senior care industry, has served in leadership positions in a variety of healthcare settings and at nationally recognized nonprofits for people with Alzheimer's disease and other dementias. So this trio is experienced in every aspect of bringing technology to help this group that we are also interested in. So I will turn it over to them to let us know what they're working on.
Awesome. Well, thank you. We're really excited about this opportunity. Our team, social science and research is really at the heart of our company, as you'll hear more about today. We've funded a lot of our product development through a variety of grants and research opportunities, but the basis of our solution is built on the work of evidence-based, non-pharmacological treatment models for dementia. So it's really an honor to present to this group because all of you, your organization, Washington State University, it's a leader in the space. And we're building on a lot of the work that you've done and are doing, the focus on non-pharmacological treatments, treating people living with dementia and their caregivers as a dyad, exploring the use of external aids and cueing techniques. So I really enjoyed some previous conversations I had with Dr. Schmidt or Edgecombe, really interactive, great discussion. So as we go through the presentation today, I'd just like to encourage everybody to ask questions along the way. We'll be able to see those questions in the chat and we can address them as we go. I know that we're making some time at the end of the presentation for Q&A, but feel free to jump in and ask your questions as we go. So as Dr. Cook explained, today I'm going to introduce the Generation Connect platform, kind of our delivery model, and describe some of the non-pharmacological treatments that it's really designed around. Then I'll provide the group with a summary of our internal research journey and how specific outcomes have really informed our product development process. Next, I'll do a demo to show you the platform, how it works. And then finally, I want to discuss our future research objectives and explain our ambitions for integrating wearable technology into the platform to expand scope of the interventions that are available, but also the outcome tracking. So with our platform, at the core, the Generation Connect platform is really two things. It's a delivery model and an assessment tool for non-pharmacological interventions. So as you all know well, there's really a lack of effective pharmaceutical treatment options when it comes to helping people living with dementia. But there's mounting evidence that non-pharmacological treatments physical activities, socialization, personalized music can be really effective, not only in regards to memory-related symptoms, but our group has been really focused on the behavioral and psychological symptoms of dementia, the agitation, the anxiety, the anger. These are really common symptoms amongst pretty much everybody that lives with a diagnosis of dementia. So within our model, non-pharmacological treatment recommendations and prompts, they're personalized based on a few things: the care recipient's interests and abilities, their need for care, their care resources. So that could be familial caregivers or it could be professional care resources, and the care environment. So to date, most of the work that we've done has been largely focused on the home care market, people living with dementia in their homes, receiving respite care services from home care agencies. So really, you're looking more at moderate to advanced dementia for a lot of these care recipients. We're collaborating with some of the top home care providers to tailor engagement programming, content, and also the assessment tracking piece of things. We really lean on families to provide the personalized inputs. When I say personalized inputs, what do I mean? Meaningful photos, a description of meaningful topics and other media. So that could be a personalized music playlist. It could be a link to a YouTube video that is connected to a topic for reminiscing. Now, when it comes to tracking outcomes, in our current model, we're really leaning on the professional caregivers. And we're getting some great insights from them. Our team is really looking to kind of follow the data to help inform the recommendations for prompts and the recommendations for content curation. So we're really looking at three types of outcome data. The first type is usage data, and that's probably the easiest to capture. How often are they opening the app? How long are they looking at pictures? How long are they listening to music? So the second type of data that we're integrating into the platform is Caregiver Self-Reports. So there's a lot that's happening with non-pharmacological treatments. It's happening offline. Social engagement routines, different types of outings, and purposeful activities. So we are deploying a series of short surveys and even clinical assessments within the platform to get some of that self-reported data. And then the last of the data inputs that we're working on is getting some more objective quantitative data. So, for example, that might be biomarkers that we're collecting via wearables, or sensors in the home, or audio analysis of the home to track things like just routines related to activities of daily living, tracking falls, and other adverse events. So those are really the three categories: usage data, self-reported data, and then more of the quantitative data. And what's really neat is the platform's constantly evolving. So the more people use it, the more precisely we can tailor the prompts and recommendations in the form of contextual training and support services. And that's really the goal. We want timely delivery of really easily accessible tips and tools. Like, we want to share the information when people need it and deliver it in a way that it's really easily actionable. So those could, just for example, like within our existing platform, those could be insights into building and using music playlists in a therapeutic context, socializing in the home, getting out and about in the community, or making time for meaningful activities, at home. And the key is tailoring the prompts based on the user. What is their relationship? Are they the person with dementia, or are they a familial caregiver that is a spouse? Are they a familial caregiver that's a child, a grandchild? How close do they live? What type of care resources are there? What's the environment? The more specific the prompts, the more effective in our experience. So as I mentioned, all of the recommended practices are really based on the existing literature. So I want to just provide an overview of the existing literature that we use to really determine the primary types of interventions that would be integrated into our platform. I became really familiar with the research in working on product development, but also prepping for some of the grants. And I find this stuff to be super fascinating, and I'm excited to be part of it and to be able to contribute to open science on this topic. So I wanted to highlight a few of my favorite studies specific to our key engagement strategies. The first one on the list is music. And I have a lot of experience with personalized music and dementia care, both professionally and personally. I really kind of served in a mentoring role for my mother-in-law, who was a primary caregiver for my wife's grandmother, who lived with dementia for 5 years. And music was such an important part of our engagement planning and all of our visits. So I kind of have a personal connection, but there's also robust literature on the topic, both clinical studies that show benefits for people living with dementia, but also brain imaging studies that are starting to expose some of the mechanism behind the effect. And with the music interventions, I just want to underscore all of this research is specific to personally meaningful music. It can't just be any type of music, right? In a lot of these studies, they use genre-based music or generic music from a similar time period as a control. And over again, we see the benefits of the music being personalized based on the person's autobiographical history. So just a few highlights, some research that came out of University of Utah, I think they first published in 2008, showed that when people living with dementia were listening to personalized music, there was activation of brain regions related to memory and emotions. And more recently in 2018, that same group published a follow-up study showing activation in other brain regions that are critical for functional connectivity and brain salience, communication between these two, between some of these critical brain regions. And for anyone that's been a caregiver for someone living with dementia, you know how important that is, especially when you're trying to get things accomplished. So that was really interesting research to us. And a similar study out of the University of Toronto, published 2021, showed repeated listening to personally meaningful music induces brain plasticity in people with mild cognitive impairment and early Alzheimer's disease. So, when I hear that term brain plasticity, the ability to form these new neural pathways, it's exciting to us because that's enhancing the ability to lean into some of these compensatory strategies and learn new ways of working around some of the memory loss symptoms that occur. So on the clinical side, there's a lot of evidence for outcomes related to enhanced mood, quality of life, caregiver well-being. Our team has done some of that work. We'll share it with you. I also cited a paper that a colleague shared with me about the therapeutic music capacities model. It's a paper out of Australia. Just really interesting because it describes the different therapeutic mechanisms, specifically cognitive, psychosocial, behavioral, and motor benefits for people living with dementia. And there's a lot of references into some of the clinical studies and the benefits that were noted in those studies. So with technology, what's exciting is personalized music is more accessible than ever. I mentioned to Dr. Cook before the talk, we're working with Apple's enterprise healthcare team and their music team to streamline the process for licensing ad-free personalized music in a healthcare context for an upcoming research study that we have. And there are plenty of offline solutions that can also be used to deploy personalized music, but they're not as convenient and they don't offer the same level of personalization as some of these online music services. The second pillar of our evidence-based interventions is social routines. There's more and more research that's validating the connection between social activity and cognitive decline. Specifically, I cited some work out of the English longitudinal study of aging, which was a decade-long longitudinal study of 12,000 people in the UK. And it showed that there's protective effects against cognitive impairment for social activity, both online and offline. In the original analysis, it showed that meeting friends face-to-face, calling them over the phone, sending emails, all of these types of social activities were associated with reduced odds of dementia and a slower progression of cognitive decline. And then in a follow-up study in 2021, it showed that supplementing conventional social interactions with online communications had protective effects against episodic memories. So even the people that were really social offline, if they weren't supplementing with online communications, they didn't have the same protective effects on the episodic memory. So that was a really kind of interesting outcome. But it's not just protective. There's also some research showing how social engagement can help people living with dementia reduce agitation and behavioral symptoms. Another study I inserted in here was also out of the UK, 69 nursing homes. And they looked at a social engagement intervention that involved less than 10 minutes of personalized engagement per day versus treatment as usual. And the intervention group showed benefits related to increased quality of life, decreased agitation, and a reduction in overall neuropsychiatric symptoms. So less than 10 minutes a day of personalized engagement showed statistically significant benefits in quality of life. So kind of our team's approach is, we think the key to optimizing social benefits involves combining online activities, sharing photos, video phone calls, messaging family members, with offline social routines that are maintained throughout the progression of the disease. So the final pillar of our evidence-based interventions is connected to purpose in life. Now that's kind of a little more nebulous concept, so it's harder to validate with research, but there's some really fascinating research or some fascinating outcomes that resulted from the Rush longitudinal perspective study. So that involved more than 900 seniors living without a dementia diagnosis in the Chicago metro area. In 2010, they showed a 7-year follow-up with those 900 seniors, and they published some outcomes that showed a person with a high level of purpose was 2.4 times less likely to develop Alzheimer's disease than a person with a low purpose score when adjusted for age, sex, education. Is also associated with reduced risk of MCI and a slow rate of cognitive decline. And then they published a follow-up in 2012, and I just thought this was totally fascinating. It was post-mortem data from 246 people that participated in the study. And what they found was purpose in life modified the association between the pathological changes and cognition. So participants who reported higher level of purpose in life exhibited better cognitive function despite higher levels of physiological changes, the amyloids and the tangles, but they still had better cognitive function when they reported higher levels of purpose in life. So we think kind of what this is pointing at is that we're underestimating the compensatory capacity of people in slowing dementia, and we think it's underappreciated, and the data is starting to validate that. And the beauty of technology is that it allows caregivers to supplement and inject moments of purpose and connection, especially when conventional routines and rituals become less accessible. We saw that a ton with COVID-19. Something as simple as streaming a church service or pulling up a YouTube video from somebody's hometown or a favorite travel destination. Those can inject little moments of purpose in the day. So our team kind of used these 3 broad categories to inform our approach to using technology to help care teams enhance quality of life for people living with dementia. So I'd love to walk you through kind of our research journey, which started around 2017. So with this initial study that we did, The product offering and the preliminary data that we captured, our goal was just like, let's simplify this. Let's keep it really simple. So we configured tablets with a few apps that we thought would be helpful for engagement. And we developed training for caregivers on how to use the apps with people living with dementia. And then we built a really simple app that was designed to collect feedback. So we received some funding from the Consumer Technology Association, Verizon, and a national home care agency to deploy tablets. We did them in a variety of settings: skilled nursing, assisted living, home care, hospitals. My partner, Debbie, who's on the call, our team's lead gerontologist, she trained staff on how to incorporate these activities and prompted them to collect feedback. So the first version of our app, it used this 8-point mood visual scale that you see on the screen. So we prompted staff prior to a tablet session, record the mood, and they could choose from joyful, happy, relaxed, indifferent, anxious, confused, sad, and angry. And then after the tablet session, they documented how they used the tablet and what was the mood afterwards. And we learned that tablets were really effective at managing mood, especially music and video applications. Games and interactive apps were far less effective. Over 50% of the sessions that were documented went from, the care recipient went from starting in a negative mood state to shifting to a positive mood state, while another 40% maintained a positive mood state. So they started positive and ended positive, which means less than 10% of the 1,000+ sessions were not effective at improving or maintaining mood. So there were certainly limitations. We didn't have detailed data related to the caregiver and the care recipient, what stage of dementia they had, what were their care resources, how much care were they receiving, the amount of time spent engaging in a particular outcome. But despite the limitations, we thought that the outcomes were really telling, just kind of as initial desirability and effectiveness. I'll share these charts afterwards. We don't have to spend a lot of time on them, but what we did is we documented all of the negative mood states, all of the participants that started a session in a negative mood. So this first chart just shows there were 408 sessions that started with a person in a state of indifference. And you can see after, over 85% moved to a mood state that we considered positive, joyful, happy, or relaxed. And across all of the negative mood states, and I'll just flip through them, it ranged from 80 to 90% shift from negative mood state into positive mood state as a result of the tablet intervention. So again, we'll share these slides so that everybody can access this and kind of dig into this. This one I thought was really interesting. People that were anxious prior to the tablet session, you can see that the light blue is relaxed. So a large percentage of them, nearly 50%, were able to move them from anxious to relaxed mood state. Again, we were working mainly with people in moderate to late stages of dementia. So of all the different care settings, we received the most encouraging feedback from those in home care. So our solution was really best suited for home care for two reasons. One, the staffing ratios. In assisted living facilities or nursing homes, it was hard to make time for personalized engagement, whereas in home care is one-to-one by definition, and there was lots of downtime. And the second reason it was a good fit for home care is there was a financial incentive for reducing behaviors and extending the client's length of stay in the home. So if the client was having less problematic behaviors and was able to stay in the home longer, the home care company would make more money, generate more revenue. So we developed a bunch of case studies that showed reductions in aggressive behavior and related caregiver turnover. And as a result of those success stories, we were able to generate additional adoption and investment from some national home care providers. And With that in mind, we built out features for the app to really appeal to the home care market. So in some of our pilot studies, family involvement was an accelerator of improved clinical outcomes. So we built out the app to allow for family members to collaborate with care professionals in a way that was HIPAA compliant and curate meaningful content to help guide the engagement sessions. So in 2020, we received the Small Business Innovation Research funding from NIH to assess the impact of some of these family-facing features. And the usage data really exceeded our, not only the specific aims for the project, but also our internal expectations. In total, there was 95 people that were using the app across 23 care recipients that were living with dementia. And family members from 22 of the 23 teams exceeded the aims threshold for usage. So on average, family members opened the app 50 times and contributed 20 plus photo shares per client over the 8+ week data collection period. And similarly, professional caregivers also were engaging with the app. Professional caregivers averaged over 70 app opens and 19 plus photo shares. So our kind of the central question around our phase 1 was, will family care partners share content to support caregiver engagement? And the answer was a resounding yes. And moreover, the professional caregivers, they utilized the content. They contributed to the content. So they started sharing photos and topics that they thought the client would enjoy. And they added what we call moments, which is just capturing kind of some of these interactions that were especially meaningful and sharing those with family members. On average, they shared over 11 moments per care recipient. So that was more than one a week. And just 3 really important takeaways from the focus groups and the exit interviews. One was that families found peace of mind and comfort in the notifications and the activity they saw in the app. We had several family members, whether it was an adult child or a spouse, that had to work, and they had some anxiousness leaving their loved one at home, and being able to see a notification on the app and check in and see mom taking a walk through the woods, or doing some other type of activity that was enjoyable, gave them some peace of mind. The other thing that we noticed is it eased the burden of communication, both between the professional caregivers and the people living with dementia, and between the people living with dementia and their family members. We had family members say, during dinner, we'd pull up the app and look at the photos that the caregiver uploaded through the day, and we would reflect on her day in a way that wasn't possible before we had those pictures to reference. And then kind of on the other side, professional caregivers would pull up pictures from the family and use that as a way to spark conversation with the people they were caring for. And then the last benefit was it helped involve remote family caregivers. So oftentimes somebody lives hundreds of miles away and they're not as involved, and they want to help out, but they don't know how. This app kind of gave them a tool to support their siblings or their parents that were kind of in that primary family caregiver role. So the phase 1 feasibility study has positioned us to pursue a phase 2 SBIR clinical research trial. So this is currently pending. So we're kind of waiting with bated breath. The scientific review is on March 16th. Not that anyone's keeping track. We've integrated some more comprehensive data collection capabilities to allow for analysis of clinical outcomes related to behavioral symptoms and caregiver well-being. So scales like the revised memory and behavioral problem checklist, the positive aspects of caregiving questionnaire. We've integrated those into the app. So I'll show you that when we demo. The executive team from Right at Home, which is a national home care franchise with over 500 US-based locations. They've been invaluable in helping us design a recruitment and retention plan to prepare for the recruitment of 250 people living with dementia and 300 caregivers. And we're really, with that recruitment and retention plan, we're focusing on, there's 500 Right at Home locations. Let's identify the locations that have mature businesses and staff that has clinical expertise in dementia care. And let's focus our recruiting efforts on those specific locations. As I previously mentioned, we're also working with Apple to ensure that all the participants have access to personalized music through this study, through the Apple Music service, which is available on both Android and iOS platforms. It's ad-free, and there's a library of 20 million songs that can be used to create these personalized playlists. So the design, we proposed a repeated measures analysis. So that involves the collection of the clinical data, the RMBPC, and the positive aspects of caregiving questions at baseline, and then monthly over the course of 7 months. So that's a pretty thorough summary of our research. And I think we're kind of at a good point now where it'd be helpful for everyone to just see how it all works, what it looks like. And I'd love to demo the app from kind of 3 unique points of view. So the first demo, I'll click around as if I'm a family member of a person living with dementia. The second, I'll show what it would look like currently for a frontline care professional, but some of these frontline care professional features, we'd love to adapt them for primary caregivers before care professionals are involved, going a little bit further upstream. And then lastly, I want to show some of the features from a case manager perspective of being able to identify some of these treatment options, deploy them, and assess how they're working. So I'm going to stop sharing my slides here for a second, I think. And I'm going to pull up my iPad screen. So let's see here if I can stop this share and move to my iPad screen. So for family members using the app, we really tried to simplify the interface and simplify the type of content that we're collecting. I think the special sauce of our app is more about how we're prompting family members as opposed to its capabilities. We send out really specific prompts based on a few factors that we know about the family member. The relationship is a big one. Is it a grandchild? Is it a child? Is it a spouse? Their proximity to the person living with dementia. And based on, and the person with dementia's stage, are they more in the earliest stages, or is it more moderate or advanced dementia? And then based on those factors, we prompt them to upload certain types of content. So for example, we might upload, or we might prompt a child or a grandchild to upload pictures of grandchildren or great-grandchildren with descriptive captions. And this is going to help with reminiscing and socialization. We purposefully limit photo uploads so that they can only upload a single photo at a time. And we have really detailed prompts on the captions, because the captions become critical, especially with the people that are in the later stages of dementia. So just a few, and now this profile is one that we actually used with my wife's grandmother for years. So I used my family for stock photography. In addition to photos, we prompt them to add topics. We have 12 different high-level categories of topics that we prompt. And then there were follow-up questions that we ask about topics. Why is this meaningful? Give us some context. And then we provide families with the ability to link content. So this is a piece of content that I've used during several visits with Bucky, who is my wife's grandmother. It's a YouTube video of swing dancing, and she used to swing dance at weddings with her husband. So this is just like a really fun video that we pull up and can be helpful for reminiscing. And then similarly with music, we're prompting families to curate music and build playlists. And we want to make it very easy for care professionals to link to this music. So for example, with this particular playlist, if a caregiver wants to open it up and listen to it, they simply tap on the link and it opens up in Apple Music ready to play. So once we work out the licensing with Apple, it really streamlines the process for making the music accessible to the frontline caregiver, whether that's a family member or a professional caregiver. And there's also opportunities for caregivers to provide feedback to the family. So if families uploaded a photo and it sparked a joyful moment, they can document that, and families are going to get an alert and see that in the feed. So really with families, it's all about curating some of this meaningful content and prompting them based on just a few key factors that we know about them. So now I want to show what this looks like from a caregiver's point of view, of kind of the primary caregiver perspective, specifically some of those self-reports that I mentioned earlier. So we're going to show this from a case manager's perspective here in a second, but a case manager can say, hey, let's activate the music intervention, or let's activate the social intervention. And depending on which interventions that they turn on, it'll prompt these weekly check-ins. And these are designed to be super short. You're able to complete them in about a handful of minutes. And it's going to give us insights into the frequency of certain types of non-pharma approaches. So for example, if we had a check-in specific to music, it's going to ask, how did Marion engage with music the week of February 15th? And there's a lot of different contexts for how she could use music. We can choose one or many of these. So let's say we were relaxing around the house listening to music. It's going to say, which days did we spend relaxing around the house listening to music? So if you're a home care case manager managing 3 different caregivers, you can kind of track who's doing what on what shifts. And then we started to gamify the process, where we're sending prompts to caregivers that we're really encouraging them to explore some of these strengths and establish these activities as routines and eventually rituals that can help have therapeutic benefits. And similar to the way that we deploy those weekly check-ins, we use a very similar mechanism to deploy the clinical assessments. These are usually happening less frequently. So this is an example of the revised memory and behavioral problem checklist. So this is usually happening more on a monthly or quarterly cadence, where these longer clinical assessments, I think this one's 24 items. It allows us to collect data specific to that. And what's neat is that we can get information about, are they completing the assessments in real time, and send automated follow-up. And then if they're not completing the assessments, the case managers will get a notification letting them know that they need to follow up and get the data. So the last view that I want to show you is if I'm a case manager. So we have home care case managers that manage anywhere from 10 to upwards of 50, 60, 70 clients and their caregivers. I can open a specific client and be able to see an overview of the check-in activity. So here's where I can turn on notification and prompts for different engagement strategies. The 3 that we mapped: music, socialization, and purpose. Turning these off or on is going to dictate not only how we're prompting and cueing caregivers, but also how we're prompting and cueing their family members. And depending on the care, the person's abilities and their resources, for example, if a client is deaf, music is probably a prompt that we're going to turn off. Or if they don't have local family to visit, we might adjust some of the socialization prompts. But once these prompts are on, as a manager, I can look at a dashboard view of the caregivers and the activities that they're reporting. So I can drill down on a specific day and see the activities that were reported, whether that's across all caregivers or if there's multiple caregivers involved in the care. I can actually filter it to just see for a particular caregiver. Similarly, I can view the assessment data that has come in from that caregiver. So that's a pretty broad overview of the app functionality. And I see there are some Q&A. I'll just jump in right now before we get to the last section. Is the choice of prompts being made by a clinician behind the scenes, or is it automated based on the data the system is gathering? That's a great question. In its current iteration, it's being made by a clinician behind the scenes. But what we're working on is using that data to inform the clinician's decisions. So we're not quite there yet. Right now, it's really based on resources and kind of the knowledge of the person's interests and abilities. And it's manually being set, but we really want to work towards a way where it's a combination of both. Do we have any other questions that I missed? Oh.
There is one over chat from Katie who asked, how does mental health, such as depression, include the effect of some of the interventions that you described, especially purpose in life?
Yeah, well, it's the data on that is really difficult to parse because depressive symptoms are kind of lumped into those behavioral and psychological symptoms of dementia that are common in over 90% of people living with dementia. But one of the things that I think is helpful is that there's a lot of overlap in non-pharmacological treatment for just these broader dementia symptoms and also depressive symptoms. So it's certainly going to challenge and complicate the efficacy, and I don't know of any data that measures that as a variable. But I know that a lot of the approaches, whether that's related to physical activity or socialization, can help address some of those underlying mental health challenges, in addition to the dementia-related symptoms.
And I don't know if this is a helpful response also, but in terms of making eligibility criteria in a research design, and you want to mitigate that separate from sense of purpose. I believe that's primarily why that question was asked also, which is a great question. We have a situation where you'd want to put down, some type of eligibility criteria that is exclusive or specific to something and exclusive of another. I mean, I don't know if that's helpful or not, but it's hard to mitigate when it's so intertwined. But I think the way the data set is set up in terms of how it's collected and how it's how you receive it is very, very helpful in addressing those kinds of situations.
So I just wanted to wrap up, and I'd like to make sure I leave plenty of time for dialogue, but I'd just like to wrap up by talking about some of our future direction. The challenge with developing technology for dementia is that it's such a vast continuum, right? And it's an unpredictable progression that typically is lasting anywhere between 4 and 10 years. So we know for certain that as a person progresses, they become increasingly dependent on their caregivers for IADLs and ADLs up until the point of total dependence in the very late stages. So the ultimate goal from our perspective is for technology to inform and guide the transition from independence to interdependence with caregivers to dependence on caregivers. And we think the inflection points are critical. The ability to more accurately flag and inform the transitions in a timely fashion, like our team thinks that's a game changer in terms of not only managing symptoms, but especially in avoiding adverse events, falls and other types of accidents. So we've, to date, have been largely focused on people with moderate to late stage dementia. And we want to go the other direction. We want to move further upstream and focus on individuals with MCI and early stage dementia. In those early stages, there's more capacity for neuroplasticity, greater opportunity to develop some of these routines and rituals that not only, have the potential to slow the progression of the disease, but it also equips individuals and their caregivers with these therapeutic tools that can provide benefits throughout the entire progression. So we think it's critical to help instill some of these habits earlier on in the process. So with that goal in mind, we're actively pursuing funding to support research and planning for product development to provide this upstream model. And integrating a wearable component is really a key component of our upstream model. So I'll wrap up here by providing an overview of our plans for integrating a wearable. And that's important to us for two reasons. One, you may have noticed the absence of research specific to physical activity when I discuss non-pharma treatments for dementia, and it's a really potent approach. It's much harder for people in the moderate to late stages, especially because of comorbidities and just cognitive challenges in general. But adding recommendations and prompts that align with the existing literature on physical activity as a non-pharma treatment, that's one area that we're really focused on. And the second is wearable data is going to help us broaden the scope of outcome measures. Right now, it's hard because we don't have concrete data on how specific biomarkers are connected to cognitive decline, but there's a lot of work that's being done in that area. And we think it's right around the corner that certain measures of physical health that you can collect through a wearable are going to give us insights into how somebody's progressing through dementia. So we think it's really important to add that component as an outcome measure. And we have a really awesome community partner in place in Washington, the Aging and Long-Term Care of Eastern Washington. This group actually introduced us to Dr. Schmitter-Edgecombe, and they're a leader in building dementia-friendly communities. They've got some funding to build out that initiative, and they're an area agency on aging. So they have really great partnerships within the regional Eastern Washington Aging Network for recruitment. So over the upcoming months, our goal is to identify a research team and a funding opportunity to support a feasibility study that would involve really three things. Integrating a wearable via Apple's Health Kit framework. We are working closely with the enterprise team at Apple, and they've allocated some resources to help us with those types of integrations. Developing really simple prompts specific to physical activity based on some of the existing literature, and deploying in the community with a focus on people living with dementia and their family care partners earlier in the disease progression. So even MCI and early stage dementia. So I know that was like information overload, a lot of information over the course of a short period of time, but I just wanted to wrap up there and kind of move on to Q&A.
Michael, there's a couple of other questions. Katie had another question. With the caregiver interface, do caregivers have access to everything in the interface that clients do? If not, how have you decided which features caregivers can have access to and which to limit access to?
Yeah, that's a great question. So there's a lot of overlap and functionality between professionals and family members. But there are some distinctions, especially when it comes to tracking clinical outcomes, how much data that we share, especially with the secondary and the tertiary caregivers. So when you think about involving a grandchild that might be like 21 years old and only limited involved, do they need access to the clinical outcome data? So we've created some ways of categorizing family members that help us determine how much of the clinical insights that we're sharing with them. So somebody that's designated as a primary, we're treating them almost as they're part of the clinical care team. They're going to have access to all of that kind of inside data and information. But the secondary caregivers, basically anybody that doesn't have that tag, they're more limited in the interface with the type of clinical data that they can see. So that's one way that we've done it. But that's something that we're going to have to continue to think through and evolve as we build out some more features of capturing data.
And Michael, too, I think it's important to share too that a lot of our reiteration of our current app is based on our work that we've already done. So we kind of are pretty flexible with moving along with what needs to be done. So, and there's another question too, Michael. What type of data and what type of threshold do you plan to use to determine if a person is in the interdependence or dependent stage? That's a great question.
Yeah, I wish I could answer that. I think we would be so much further along if we could answer that. But I think it's really a combination of things too. And I don't think there's going to kind of be like this clear cut point that we can say with certainty.
Mm-hmm.
But I do think that's going to be a combination of some of the self-reports that we're seeing for caregivers, and also I think that's where there's real opportunities with more of the quantitative data that we're collecting on the back end. I always hesitate to talk about artificial intelligence. I think people kind of like wave around their magic artificial intelligence wand too often, and it's not always relevant. But in this instance of like thinking through that question, which I think is like a very difficult question, that if we can answer it, we're gonna see some awesome benefits. But I do think that AI does have a role to play in that. When you're looking at usage patterns, whether it's on device or through sensors, or even there's some companies doing some really cool stuff with audio collection and analyzing the audio data to determine people's patterns in the home.
Yeah, Alexa does that, yeah.
Well, not so much Alexa, but there are some companies that are using that to track like ADL routines and adverse events in the home. And I think that's an area where AI can really shed some insights, even more so than some of the methods that we can use to kind of get a jump start on that.
But there's also an inflection point too. Who uses the app? When is it used and how often? That's why our weekly check-ins are really, really helpful to us to understand that interdependence versus dependence. It's scary because in dementia, it goes back and forth. It goes up and down. It could be like stage 3 today and stage 2 tomorrow. So, but I think that our data collection tools actually give a little picture into inflection points that are important. So I don't know if that answers your question or not. But.
Do we have any other questions or thoughts?
Yeah, any other questions? You can also raise your hand if you want to ask it yourself. I am curious because we're trying to collect behavior markers from wearables. If you've given thought to what kind of biomarkers you want to collect from the wearables in your future work.
Yeah, well, I think that using some type of measure of heart rate as an indicator of adverse events, I think there's a lot of potential there. I'm not sure of the specifics of how that would work, but I definitely think there's an opportunity to use some of that wearable data to kind of flag agitation or aggressive moments. But just honestly, and this is why I would be so tickled if we could figure out the funding and research partners to do feasibility study. I think there's a lot to learn just in, it's like the basics, steps, movements, calories burned, that type of stuff, to just look at some of the patterns there between behavioral symptoms and physical activity, because I think that's a really underexplored area. And now we have the tech to make that more seamless. Although there are some challenges with getting people to wear the wearables and making sure they're charged and all that fun stuff.
And I'm also a fan of the investigation of sleep and sleep patterns, because we know that sleep cleans out the brain. So that has a huge effect on cognitive decline. So, and tau and all of that accumulation. So I think I'm a fan of that too, but that's just my own personal preference. But there's been a lot of research on that recently. So
this question is intriguing me. I'd love to hear this person speak more towards this. I don't know. This is about the Glades, Florida study. I'd love to hear more about that.
But Larry also had a question too on the results comparing audio only social interactions versus video interactions. There is actually.
Yeah, well, we don't have specific data on that of the whether phone calls versus video phone calls and the efficacy of one versus the other, but definitely something that would be worth exploring kind of in future research. That's one of the challenges is any data that we collect through our platform, it's easy to aggregate the usage data. But if things are happening off our platform through Zoom or FaceTime, we don't have the access to the granular data there to include that in our analysis. So something that we're in the process of reaching out to some of those companies and getting more granular data so that we could really kind of compare the clinical outcomes when we look at the something like that, video interactions versus audio only.
And some other really good questions too. And the Glades, Florida study, we could get information about that. That looks fascinating, Lisa.
Yeah, the question from Dr. Schmitter-Edgecombe about envisioning professional clinicians being in the loop, that's our goal. I mean, we really want to kind of expand the access to the platform to the entire care team. We're working right now with a company that provides HIPAA compliant messaging to physician groups and kind of integrating our solution with their solution so that we can kind of have this open dialogue between various members of the healthcare continuum and the family members for leveraging some of these non-pharma approaches and assessing outcomes. So definitely a goal is to kind of broaden the scope. We're working with select like hospice teams and like OT PT teams, providing them access to the platform and the profiles in combination with some of our home care partners. So that's kind of a small expansion, but we really love to just open it up to any healthcare provider that could benefit from having access to the content.
Other questions from our attenders today?
Yeah, it was really fun.
I would like to ask one more question before we leave, and that is based on your experience designing the app and experience in getting feedback from the app. Is there one overall lesson learned about designing these interfaces for older adults and their caregivers? you could share as we are designing interfaces as well.
Prioritize. I think one of our things our product team does really well in designing UI is not thinking about what we can add, but thinking about what we can take away. Like that's always like, do we need this feature? What features can we take away? How minimalistic can we make this experience? And that's our starting point. We are very protective about what we add to the app. And I think that's been really beneficial in driving adoption early on. The first version of our app could only do, I mean, it was so basic, it was amazing. And we built it in a weekend. But along the way, we've only added features after they've kind of been validated as a way of iterating on our original product.
That was a fantastic answer. I think for many of us, that is just the perfect note to end on. And I want to thank you for your time, your insights, and congratulations on your successful mobile platform. Best wishes for the next step. And we are here to talk more. We enjoy what you're doing.
Awesome. Yeah, I'd love to continue the conversation and continue to collaborate with this group because you guys are doing incredible work and kind of leading the way in the space. So we'd love to be part of it.
All right, we'll follow up on that. Thank you again, everybody.
Great.
Have a great day.
Wonderful. Wonderful. Too. It's been an honor. Thank you so much. I look forward to more communications.
Take care, everybody.
Have a good day now. Bye-bye.
Bye.